Thank you very much for attending our second National Thrombosis Seminars of the year. The topic for today is going to be the global burden of VTE, what we can infer, and the road ahead. So just as a friendly reminder about the National Thrombosis Seminar Series, so these are monthly seminars that are hosted live throughout the academic year, featuring state-of-the-art thrombosis and venous thromboembolism lectures presented by both Canadian and international experts. The video recordings of the seminars are available after the seminars at canvector.ca. And just a reminder that these seminars are a self-approved group learning activity as defined by the Royal College of Physicians and Surgeons of Canada. So I'm very happy to introduce our speaker today on the global burden of VTE. So Dr. Behnood Bikdeli is a cardiologist and vascular medicine specialist focused on thrombotic diseases. He has led or contributed to dozens of clinical trials and observational studies with over 290 publications, nearly half as lead or senior author. Dr. Bikdeli is associate physician at Brigham and Women's Hospital, assistant professor at Harvard Medical School, and investigator at both the Thrombosis Research Group at Brigham and Women's and the Yale New Haven Hospital Center for Outcomes Research and Evaluation. He serves as an associate editor for thrombosis research and the New England Journal of Medicine Journal Watch for cardiology. He's a section editor for thrombosis and hemostasis and executive associate editor for JACC. His research includes the Inspiration trial on anticoagulation in critically ill COVID-19 patients and methodological leadership for RIETE, the world's largest VTE registry. His current interests include large-scale analyses, often integrating AI to assess thrombotic disease burden, the role of antiphospholipid antibodies in thrombotic diseases, and comparative effectiveness of pharmacologic and device-based therapies using observational designs or clinical trials for venous or arterial thrombosis. The learning objectives have been circulated and you can see them here. And just another reminder that so the presentation will be around 30 to 40 minutes, and then there will be a 10-minute Q&A period at the end of the presentation. You can write your questions and answers in the Q&A box, and then we'll bring them up to our speaker, and hopefully we'll be able to get a bit of interaction as well. But with that, I will hand over to Dr. Bikdeli. Thank you very much.
Thank you so much, Dr. Shaw. Good afternoon to all of you. It's a great privilege and honor for me to be here with you. And I'll be discussing about the global burden of venous thrombosis to the extent that we've already learned some information over the past 2 years in this longitudinal effort. And I hope that we generate more discussion today, and together we would be able to learn even more, such that what we do today can inform and share better care for our patients tomorrow. Here are my disclosures, but none are specific to this very project that I'll be discussing. And it would be completely unfair if I didn't showcase many colleagues who've been helping shape this project. I'm going to name Sina, Mariana, and Chris, who've been really the driving source in the day-to-day work for this project, but several senior investigators all around the world. It's truly a team effort, and we still have much more work to do, but I'll be providing some interim estimates with you, what we've learned so far. And part of the reason we are going to need to discuss it, of course, for this audience, is relatively speaking well known. Venous thromboembolic diseases are the third most common cause of vascular death after MI and stroke, and one of the most common and preventable causes of in-hospital mortality. And it's, in the developed world, the most common cause of maternal death. It's a major contributor to debilitating non-fatal enduring complications as well. And of course, all that comes without saying that it's extremely costly. And the burden of thrombotic diseases, particularly venous thrombosis, has been to some extent looked into before. This is one of the very first pieces that I am personally aware of. More than 10 years ago, Gary Raskob and the team at ISDH tried to put this piece together, and it was very helpful at the time, very innovative and novel. And you can see that they listed a bunch of papers, different time periods, all the way from 1990s to like early to mid 2000s from several different countries, Germany, Norway, France, Sweden, US, Taiwan, Hong Kong, etc., trying to share some information in terms of incidence per 1,000 populations per every year across the spectrum of age groups. So being one of the first systematic attempts has tremendous value. But as you can see, they're just coding studies. It doesn't include construct validity of the individual studies. So what if one of the studies didn't have good methodology? What if the estimates were not accurate? Also, these are single studies. Like, how do you infer one study from this region or the other? Or you're seeing 3 separate studies from the US. So which one do I believe with all the heterogeneity? So those were kind of the opportunities for improvement. Plus, there was really no regional or global map shared in the estimates that were shared here, and no details on outcomes either, or how the trends evolved over time. That being said, again, this piece has been cited over 1,000 times, very well worth it because it's such an incredibly important topic. By the same token, there was a sequel piece that Aaron Wendelbo helped with. And this time around, they're trying to share estimates for a bunch of thrombotic conditions, so ischemic heart disease, stroke, atrial fibrillation, but as far as our conversation is concerned, on the right-hand side, venous thromboembolic diseases. And here, unlike the prior slide, you see that the authors generated some estimates for incidence, but also mortality, disability-adjusted life years, etc. So again, incredibly valuable. But also there is a caveat here. Again, one of the very first studies, but if you look, they have citations and you can go and check back the source papers. But they use a total of 3 papers to talk about the global burden of venous thromboembolic diseases. Are we really bound to 3 papers in isolation to provide these estimates? Probably not. So again, incredibly valuable piece and very innovative in bringing it front and center to people's attention, but from a methods perspective, also indicative of a lot of room for improvement. Now let's shift gears a little bit and talk about the Global Burden of Disease Collaborative. So the GBD Collaborative is run by a group, IHME, from University of Washington, with a lot of collaborators, and this is directly from their website. They talk about 607 billion plus standardized estimates that they share for multiple disease conditions across over 200 countries. And there would be numerous papers either by the IHME group, or they do have some sources to download such that independent groups can also go and present their own results. And it's really an enormous effort. Huge congratulations for what they do, except for if you dig deep, when it comes to the VTE codes, they have something called garbage codes, and they're going to dump all the venous thrombosis codes into garbage. So for that reason, if you look at some of their highest impact publications, including this Lancet piece, but even in JACC last month, they presented another paper of global burden of cardiovascular diseases. They report on a zillion things from stroke, COPD, diabetes, a lot of other risk factors, et cetera, et cetera. But I looked high and low and there is no VTE among them. So to me, that's a major challenge or an opportunity for others to look more. Another piece to kind of tie it together, why do we want to look at estimates right now? In terms of diagnostics, there have been a lot of changes over the past 2 decades. We are now using CTPA time in, time out, instead of VQ or sometimes just guesstimates. We also have very good clinical prediction rules. Shout out to many prominent investigators in Canada who were really the world pioneers in use of clinical prediction rules for that purpose. So we are using them. We use additional laboratory markers, and then we go to CTPA for more accurate diagnosis. Separate conversation that there might be a component of picking up softer cases of pulmonary embolism, but all of these are hinting towards some shift over time. The risk factor profile over the years has also changed globally. We have more of an obesity pandemic. There is global aging, and with that comes 2 things. A, increase in prevalence of cancer and chronic cardiovascular conditions, and B, it's great that we've gotten better at cancer therapies and cardiovascular treatment of non-VTE cardiovascular conditions. However, with that comes a pool of patients who are surviving longer and remain longitudinally exposed to the risk of venous thromboembolic events. And venous insufficiency, whose prevalence gets higher over time, doesn't certainly help with that. For prognostication, we've also similarly had improvements. So we are using HESTIA criteria, PESI, SPECI, DESC model, or some that are actually coming, and you're going to hear more about them over the next couple of months. And all of those have helped improve and or will continue to improve how we think of index venous thromboembolic events and think of triaging the level of care, processes of care for cases with severe disease involving multidisciplinary teams, and ultimately trying to bring together a host of pharmacotherapeutic options, and for less sick individuals, trying to help them go back to their setting of residence, most often home soon enough, or if they're really sicker, to think of a series of endovascular options or occasionally surgical tools or more aggressive pharmacotherapy options to help them live better or longer. But in the face of everything that I discussed with you, we are still lacking good data. I showed you the IHME group, the GBD group, is saying these are garbage codes. We couldn't care less. We're having all these epidemiological and treatment-related changes over time, and still nobody knows what's going on around the world. So we highlighted that actually in a global burden of cardiovascular disease issue of JACC this very month a few days ago, and this is a QR code if you're interested to go and read this commentary. But essentially that was a call to action that we need to do better, we need to do more about this. It's a very common cardiovascular disease, and in my humble opinion, unacceptably neglected from the global burden of disease estimates. I do hope we do better together. So the aims of what I'll be presenting to you over the next few minutes is to provide a systematic overview of how incidence and outcomes of venous thromboembolic diseases have evolved over time, and to share some global perspectives and also reflect on areas of improvement. But before I start sharing plot after plot, I think it would be equally important if I try to explain away some of the methodological considerations that we had. That way, at all the pieces of the results that I'll be sharing, the strengths of them or the limitations become clearer. So the first piece was we really tried to put together an inclusive, collaborative international group in order to get some of these estimates. And we are going to share some estimates for incidence and hospitalizations as a primary measure of that, recognizing hospitalizations do not always capture measures of incidence. In certain cases where available, we try to also resort to some conversion or get outpatient records. But where they were not available, that's one of the future opportunities that I will be discussing. For mortality estimates, there are many ways that you can look at them, and it could be all-cause mortality or mortality related to PE. And of course, you can report them for the population or for the people who've had venous thromboembolic diseases. In all the plots that I'll be sharing over the next few minutes, we are going to report the analysis separate for pulmonary embolism and DVT, in large part because VTE as a big bucket hasn't been reported in a reliable way in most regions of the world. If and when one day they are able to lump them together, we would be able to report. But because there is some overlap, we wouldn't be able to do that at the aggregate level unless the primary investigators do that separately. And the outcomes data, but not incidence at all, as I'll be alluding to, were also complemented by findings from large registries, those that at least had 1,000 consecutive patients included. And in order to be illustrative, we actually picked two time periods, 2012 to 2016 and 2017 to 2021, to understand how things are going. And we studied papers that were published from 2012 onwards, and our main outcomes of interest were measures of incidence and measures of mortality. And it's important to talk about this mortality rates. Many people, myself included in prior publications, very loosely refer to mortality rates. But really, there could be two different ways we are talking about this. One is when you're talking about a population, say Canada, US, France, any other country. If you're reporting it per person, years of total population, that's truly a rate from an epidemiological perspective. But if you get 400 people with PE and you're reporting X% of them died over 10 days, 20 days, or whatever, that's truly a proportion, not a rate from an epidemiological perspective. Many of us, when we write papers, loosely refer to that as a rate. Because this is a methodical work, here we are referring to that as a proportion, which is the semantically correct term here. And as I was alluding to, we can report all of these for different numerators and denominators. Incidence is very telling. New cases over a population of at-risk individuals over time. Mortality rates, as I shared with you, we're going to report them per the entire population. And also we're going to report proportions who die from any cause, much like the same as case fatality proportion, but also those that are related to PE separately. And this is a graphical summary of what I was discussing with you. So we're going to have a population of people with PE, and they're going to die from anything, including but not limited to issues that are directly affected by the pulmonary embolism. And we're going to try to generate the estimates separately for these groups and subgroups. And all of these are, of course, a smaller subgroup from the general population. And we're trying to report these estimates. This is one of the last method slides, and hopefully we will dive into the heart of the matter. We are reporting the estimates by countries, but we also have ongoing effort, most of which I'll not be showing to you today, to group them to 8 larger mega regions according to the GBD IHME grouping of these regions, such as North America, Latin America and Caribbean, Asia, Oceania, and so on and so forth. And this is one of the illustrative works that helped us a lot tremendously in the mortality component reporting. It's great work by Stefano Barco and team from the WHO mortality database. I just wanted to show you there is so much precedent work, and of course there is good reporting, and heat maps are a nice way of graphically summarizing. But here we try to also make it digestible with global heat maps. And we also try to ascertain the methodological quality of individual studies. So we use the Newcastle-Ottawa scale for screening the methods, but we also ensured that the individual included studies had some kind of validated tools to report DVT and or PE, because it's very easy to use claims data, but it becomes incredibly unreliable if we just simply put claims data codes, ICD codes into a large data source, and without ascertaining validity of that approach, try to make clinical or epidemiological inferences off of them. They could be notoriously inaccurate. Where needed, if the studies were valid but only had a subset of individuals, we also used current best evidence from other source studies that had validated those populations to come up with conversion factors. And in terms of registries, I shared with you that for some of the outcomes data, we also tried to complement the population level estimates with data from large registries, including Riate, Garfield, and many others that have enrolled patients with robust construct validity and in a way that conforms with the study period that we had in mind. However, we should always keep in mind that these registries do not have a denominator of total population, so they're not suited for getting estimates for disease incidence, and we did not use them for that purpose. This is a summary of our search terms, and suffice it to say that we looked very well more than 2,500 citations to get to where we got. Okay, here we go. For pulmonary embolism, in terms of incidence between 2012 and 2016, you see that there is a lot of heterogeneity, including between Canada and US, more than a 2-fold difference. In Europe, there is so much more. In China, they're reporting probably 10-fold less than the US, probably 4 or 5-fold lower incidence rates compared with Canada. Australia is more or less mirroring the US. And importantly, probably the single most important finding on this slide, you see so many countries and regions gray, including almost the entire Africa, South Asia, and many others. What this simply means is we lack data put aside like great quality or not, we lack systematic data in these regions. And when we go to 2017 to 2022, it gets worse. It doesn't get better. And as you see, for some places, including Canada, and after my conversation, if we haven't been able to identify, that's one of the benefits that I was looking for from this conversation today. Please point me out to a reliable national study of pulmonary embolism incidence from Canada that has been published, that we may very well have not been able to find it yet, but inclusive of 2017 to 2022. But many other countries, more of the same issue. For the rest of them, you still see some heterogeneity. And for the countries that do report it, let me just go back just so you see the difference. In the US, you see some increase. In China, you also see some increase. Australia, give or take, stable. And many other regions, as you see, we do not have data. How do we do with mortality as a population estimate per 100,000 person years of follow-up? You see US is around 2.2, Canada is 1.3. Many other countries are hovering around that range, but I'm just going to share a couple of others with you. Look at the Dominican, for example. It's 23, it's almost 10 folds higher than the US, and I'll come back to that when I want to summarize some points for you. And when we go to 2017 to 2022, again, US and Canada estimates for mortality per population, you can see that very slightly they're going up, but really not dramatically so. But again, if you look at places like Dominican Republic and many other Caribbean regions, they are much higher, even if in numerical values they've gone down compared with the past. And again, we don't have any data from most of the African countries. We do not have any data from India or many other regions around the world in terms of population level estimates for mortality, including from China. By the same token, if you look at PE as underlying or contributing cause, because as we shared before, in these large-scale population level estimates, PE can be either underlying or contributing, and then you can lump them together. When you lump them together, understandably, so the absolute values are going to go up. But again, there's not going to be a huge difference. And you see that in Europe, from 2017 to 2022 at the population level, we were able to only find a single study from Italy. The rest of the Europe, it boggles my mind, but we were not able to find anything. If you look at all-cause mortality proportion, now we're talking a different estimate. Remember, we were talking population level, and then we were saying, let's take a denominator of patients with PE. This is population level. So if the denominator is PE, patients with PE, short-term mortality up to 30 days. In some cases, if they shared in hospital instead of 30 days, we settled for that. In the US, it's about 4%, Canada 3.2%, and the rest of the world, it's not like hugely different. Some other parts are saying 6%, 5.5%, occasionally some other countries, very low numbers like Russia 1%, Turkey 1%, some other countries the same. And if you look at the more recent years, 2017 to 2022, you see that some of the numbers are going up, for example, in the US, whereas in some other regions, they're farther going down. And when you look at the PE-related mortality, so essentially, that's the proportion of people with pulmonary embolism whose cause of death was thought to be most likely pulmonary embolism. So that's essentially a little less than 50% of deaths across the board, across the regions. And for some countries, we do have the estimates. For some others, we are missing them. Excuse me. So for more recent years, as you see, for PE-related mortality, most of the regions don't have anything. It's only a couple of countries in Europe, Australia, and Japan that are sharing some reliable estimates. And we're going to get some more through registries. That's work in progress. But from the published reports, as you can see, we are missing so much. Now let's quickly talk about deep vein thrombosis. And as you can see here, for population level estimates, you're seeing even higher numbers for DVT compared with PE. In 2012 through 2016, again, the vast majority of countries did not report population level estimates. Even in Europe, goodness, you're seeing only 3 or 4 countries that did report published, peer-reviewed, methodologically reliable estimates in 2012 through 2016. And when it comes to 2017 through 2022, again, there are only very few countries that reported estimates in ways that we could ascertain. For recurrent venous thromboembolic diseases, similarly, we were challenged. The good news is we didn't have data from some large registries to fill in the numbers. And you see that in some regions, they're reporting in Saudi Arabia as high as 15%. I don't know how that happened, but in most other regions, it's somewhere between 3% to 5%. US is probably an outlier at 8.5, but most other regions, you see that they're internally consistent and reporting lower rates. And for more recent years, we still have more work to do. Okay, I shared so many slides, lots of plots with data, but where does it take us? I think one of the important points I hope I've been able to convince you is we have so many regions with missing data. That's one of the key limitations in how to move forward. And this could be in part due to limited diagnostic availability, limited resources, lack of having surveillance systems, or even when they have it, the surveillance systems there may not be reliable. They may not have data audits, etc. And we saw that was a huge problem in Africa, but also likely a problem in South Asia, Latin America, and even in some of the Western countries where we did not have regular updated reports for these conditions. And many of the estimates are of uncertain reliability. That was another challenge that we faced. And I think there are many issues with that. One is that some investigators think so long as they have an ICD code, they're good to go. They can put it into the system and it's going to spit back numbers. The problem is it really doesn't work in that way. You really need to validate the approach with these codes. It's much like any other diagnostic test. Unless you prove the diagnostic accuracy, specifically sensitivity and positive predictive value, we are running a bunch of coding exercises and we're going to make clinical inferences off of them. Sometimes there could be limited volume. Sometimes there could be issues with the construct. And in order really to have better reliability and limit this dramatic variability that we've seen across individual studies, the key would be consistency in methods and implementation of better methods. Also, we had some striking findings. I showed you that some of the results in the Dominican, for example, were 10-fold higher than United States, for example. I genuinely do not think we are having a pandemic of venous thromboembolic diseases in such way that the country like Dominican has a hugely worse epidemic of the disease compared with United States, Canada, European countries, and Asia, which, by the way, in the heat of COVID-19, was cut nearly into half rather than going up. So that's one problem. And second, I didn't show you all the details, but many of the countries, interestingly enough, even when we were looking at year-by-year data, they reported a decline rather than an increase in their incidence of cases with venous thromboembolic diseases in 2020, a year that many of us who happen to be clinicians as well are absolutely 100% confident there was an increase, not decrease, in the incidence of venous thromboembolic conditions. So what does it tell us? I think it's sufficiently telling that we were under capturing these conditions. Many of the people Shehan, I, and others have published in the face of the pandemic were not presenting into the emergency rooms as often. For those who were, there were limited resources. There was concern for exposing healthcare workers, etc. So we were not sending all of those with suspected PE for a CAT scan, etc. So there is huge misclassification, and some of the countries may have not even had sufficient infrastructure and resources to allocate to continue to complete claims-based of surveillance of these conditions, including venous thromboembolic diseases at the time. So all this to say, yes, we are having some interim estimates, but there are so many holes in them. Some of the national estimates and international estimates for other cardiovascular conditions that you see published even in top journals, they're going to give you beautiful plots. You're going to report them in your future papers and grant applications. But really, it's important equally, in my humble opinion, to report some interim estimates, but also to transparently disclose what the major challenges with existing data are, because it's only that way that we would be able to collectively do better tomorrow. And that's some of the points that we tried to highlight in the viewpoint that we had in Jack a couple of weeks ago. So now, instead of this question mark, I shared some interim estimates of the incidence and outcomes of pulmonary embolism and deep vein thrombosis around the world with you. However, in the face of all the epidemiological changes that I shared with you, we're also cognizant that the GBD estimates systematically excluded them, that we do face areas of data desert, including in Africa, South Asia, etc. And the studies that do report the outcomes, including incidence or mortality, have used so many heterogeneous methods that it's really difficult to lump apples and oranges. I always share with my research group, I'm okay if we lump different groups of apples, but apples plus oranges, there is really no easy way to lump them together. And registries can help us inform some of the outcome estimates, but not for incidence. So how do we do better? Part of it is the international collaboratives, much like the one that I've been fortunate to be a part of, from which I shared some of the interim estimates with you. But we really need to do better prospectively as well. Harmonize the key data elements from studies that are gonna analyze national estimates in future. I really hope we get more from Canada, but also more from elsewhere around the world to have good regional and national estimates. It's only then that we get harmonized national estimates. Then we can pull them together and share back global estimates. And in future, I'm really hopeful that there would be even more prospective data harmonization and coordinated efforts to generate estimates. And another futuristic look, as all these healthcare systems continue to improve and implement electronic health records, there is a world in which, maybe not too far from now, we can use advanced natural language processing, maybe large language models, to ascertain these events within health systems, then pull them together within regions and countries, and then scale them up toward global estimates. So we do still have some work in progress. As I shared, there are areas of data desert, issues with inaccurate estimates regionally and hence nationally and globally, and lots of between study heterogeneity. Last but not least, all this work that I presented was really literally with zero external resources, just out of our love and interest in the topic. But hopefully, if and when we would be able to secure funding to carry this forward, we can dig deeper and report results, including across many vulnerable subgroups, such as those with cancer, older adults, pregnant individuals, and many others. And I think ultimately having the accurate estimates of incidence and how outcomes evolve over time would be very helpful, because it's only then that we would be able to have a robust look, update national guidelines, come up with systemic surveillance methods, and modify resource allocation toward where problems are. For example, if one region is having more issues with incidence of the disease, the problem really lies in primary prevention and better use of prophylaxis. Whereas others do not have a high burden of incidence, but they have an unexpectedly and unacceptably high rates of mortality. That's where we need to focus the resources and see why there is systematic under and or overuse of advanced therapies. We have to look at comparative effectiveness of different treatment options and even comparative effectiveness of policy measures. To me, health policy is no different from other health interventions. So if we want to implement something, why not do it with the beauty of randomization, including cluster randomization, such that, again, what we do today informs the tomorrow for all of us. And targeted quality improvement through such designs, in my humble opinion, is going to be more effective than simple before-after designs. I know I talked a lot, but let me try to wrap it up, and then I would love to hear your perspectives about it. I hope I've been able to convince you that many countries do not have minimum required data to generate estimates for global burden of disease. However, we did share some estimates for now. The data from many regions are old, but some of the estimates that we had are indicative of maybe a higher burden of VTE. Is it because of better disease detection, as I was sharing with you, with better diagnostic algorithms and or use of tests such as CTPA? Is it because of better reporting or all the above? For me, it's hard to tell from what we have, but I'm hopeful we get to learn soon more about these. And I think we need to do better efforts, more collaborative investigations, such that we would be able to generate high quality knowledge and would be able to understand who the most vulnerable subgroups are and how their outcomes are shaped. Thank you so much for your attention, and happy to discuss further with you and also learn from your thoughts.
Thank you very much, Dr. Bikdeli, for that really fantastic presentation. Lots and lots of data, and as you were presenting, I was thinking of one question here that it's maybe more of an interest. I know you have a bit of an interest in AI, and you briefly mentioned natural language processing. You know, epidemiology and diagnosing VTE is to some extent subjective, right? And what is, even if we define it as symptomatic versus asymptomatic in screening, you know, what is symptomatic can be subjective both on the patient's part and also the physician receiving that information. And so I'm wondering, like, you talked a little bit about how you know, we're using diagnostic imaging more, and anecdotally I find that maybe the threshold for requesting imaging is going down, at least here in Canada. And so, you know, how can we adjust for that? How is there a way that we can mathematically adjust these incidence estimates, taking into account for the fact that maybe we're, you know, imaging is a bit more available now, and we're doing it way more, and the threshold to order an ultrasound, for example, or a CTPA is lower, or do we just need to maybe consider it and avoid comparing to data, you know, 20 or 30 years ago?
No, those are great comments. Thank you very so much, Dr. Shaw. And I'm going to break them down to 2 or 3 chunks such that I would be able to share my perspective about them. I think one of them, exactly as you mentioned, is particularly with 2 background conditions, A being cardiovascular diseases and B cancer, you're getting a whole host of additional imaging tests. I cannot tell you of the number of patients who've gotten like a pre-TAVR CT or CT coronary, etc., who incidentally happened to have some cells of filling defects that got referred to me for opinions related to management of pulmonary embolism, but also more common than that for patients with cancer. Many of them have contrast-enhanced surveillance imaging for their cancer, and people pick up all kinds of thrombi, and then be it splanchnic vein thrombosis, IVC, or more commonly PE, and to what extent do they really represent disease, embolic disease versus tumor burden, etc. I think all of them have some inherent uncertainty. But the second layer is, how do we do better? I think one component of it, which we cannot do right now, but maybe a futuristic look, is to do subgroup analyses with and without these cancer and cardiovascular diseases. If we see even in all comers, there is a similar trend, it's hard to adjust for your point in better availability of diagnostics or change in the threshold of individuals, short of a prospective, separately funded study, but it would give us some insights. And there's a second piece to it, which you elegantly shared. How do we make better use of AI? I think it's really futuristic, because for now, almost all the surveillance systems that I know of at the national scale use administrative claims, not full access to EHRs. So you're not going to be able to use NLP to scale it toward that. But I don't know, maybe 3, 4, 5, 10 years from now, when the PHI concerns and data security concerns are better mitigated, then I think becomes a time for better use of natural language processing. We just validated a hybrid approach. Hopefully it's going to come out over the next couple of months or 2 with the traditional NLP. But large language models are really 2.0 in that perspective, because if you can harness them effectively and validate against a group of experts, I think they will make things a lot more efficient.
Yes, yeah, and even part of me wonders, maybe not even natural language processing, but even just imaging analysis. You know, like we talk about, maybe the severity of the disease is going down because we're overdiagnosing, right? But even a radiologist's interpretation of the extent of thrombosis, right? We see this all the time, and clinical practice, at least here in Ottawa, where what is considered extensive versus not extensive is very subjective, right? And it's not to say that AI is necessarily standardized, but maybe if you're using the same model, across interpreting the extensive thrombotic burden, maybe it's a way of standardizing the interpretation of disease severity.
I agree with you completely. And I just put in the chat a shout out to my good friend and colleague, David Jimenez. He just had this piece of systematic review of the clot burden and prognostication in PE. It goes a little off topic from what you're describing, but I think it's very important because there is potentially some value in looking into it. But the point estimates for the impact is not huge. But what you shared is very exciting to me, like radiomics, making full use of the radiology data, plus the other omics and even clinical information. Maybe it will help better for prognostication. One part of it is for transfer epi, but one part of it is also for our day-to-day practice for patients.
Thank you very much for sharing that. I'm just looking at the Q&A box here, and Dr. Shu from here in Ottawa has a question related to given potential practice variations in different geographic areas, and there might be differences in how anticoagulants are used, how anticoagulants are prescribed. He's asking, have you seen any, do you have a sense of the quality of the data capture as far as how VT is being treated and how that might affect the incidence data that you had presented about recurrent VT, for example?
This is another incredibly important comment. And as we are essentially writing up some of these results, as I shared with you, it's been commissioned for one of the journals. We are actually trying to disclose transparently, but the limited resources that we had, we were able to opine only on 3 things: incidence, all-cause mortality and PE-specific mortality, and recurrent venous thromboembolic diseases. Use of antithrombotic therapies, advanced therapies, background risk factors, how those have evolved over time. Absolutely important for inferential estimates, for understanding this led to that, why. Those are very important questions, just that between having nothing versus what we're presenting, we figured having something is better than nothing, but taking it from here to the next level is absolutely something that should be done. And I'm hopeful someday, and not too far from now, we would be able to get funding to do these much needed investigations.
Yeah, thank you very much. I don't see any other questions in the Q&A, so maybe if there are no other questions, we can leave it there. But I just wanted to say, Dr. Bikdeli, thank you very much for the presentation and for sharing this very interesting data with us. And just to also say that the next seminar has already been scheduled, and this is going to be January 15th, 2026. This will be Danielle Roy presenting on biomarkers and genetics for the prediction of venous thromboembolism and clinically relevant bleeding in cancer patients. But again, thank you very much, Dr. Bikdeli. This was a really great session, and we appreciate you presenting for us.
I'm very grateful for having me, and I wish all of you happy holidays and a great 2026 to come. And my heart goes to all the people who suffered from brutality over that past couple of days as well. Wishing you all the best and enjoy the rest of your day.
Thank you.